Barbara and Marie, I see that you're here with us tonight, so welcome. So, whereas our most precious resources are our children, the first years of a child's life lay the foundation for all future learning where the most rapid brain development occurs. Whereas early literacy is the gateway to all learning, from birth to third grade, we learn to read so that we can then read to learn. Statistics show children who are not reading on level by the end of the third grade have only a 1 in 4 chance of success. Whereas literacy is the key to individual success and our community's economic prosperity with a $13 to 1 return on investment. Whereas we know schools can't do it alone, as roughly 44% of our children are behind when they begin kindergarten. Therefore, we must build literate communities and support our families as their child's first and most important teacher. Whereas while reading scores through the state and nation have declined over the last 8 years, Indian River County has increased the number of third grade students reading on level to 60%. Since COVID, we have risen from 31st in the state rankings to 7th place. Yet our work is not done, and we are dedicated to reaching our moonshot 90% literacy goal. Whereas literacy and health are interconnected, limited literacy is a barrier to accessing health information, proper medication use, and utilization of preventive services. Individuals with limited literacy face additional difficulties following medication instructions, communicating with healthcare providers, and attaining health information, all of which may adversely affect their health. Research has also shown a positive correlation between limited literacy skills and chronic conditions, including diabetes and cancer. Whereas the state of Florida has also declared Moonshot 90% literacy goal, which recognizes kindergarten readiness and third grade reading to be critical milestones in becoming a top 10 economy by 2030. Whereas the Campaign for Grade Level Reading has annually declared our Indian River County Moonshot Community Action Network as a national pacesetter to honor us for the community-inspired literacy moment. Whereas it takes trusted relationships, teamwork, and early education policy to create a moonshot community where 90% of our students are reading on grade level by the end of third grade. Now, therefore, we agree to join the Moonshot Moment Journey, team of teams, and commit to working together as moonshot leaders in 2024 to make Indian River County, Florida, a leading literacy capital of the nation. This means taking a stand for our youngest citizens by improving early literacy and giving every child the opportunity to be literate, productive, compassionate citizens who will improve our world. We thank you. That's our commitment.
Thank you, Mary Beth, and we're so appreciative of the hospital district. We have some of the MCAN, our Moonshot Community Action Network folks are here. We have more in the audience. So many of you have been part of it. I wanted to ask Barbara, and if anybody wanted to just share a few words about that. And also, when I sent that, since I sent that, the scores have been recalibrated, and our county, Indian River County, our school district is now 5th in the state for third grade reading. So we said 7th. And when we sent that, the numbers showed 60%, but 63% of our students here are reading on grade level right now. Our goal is 90, so we've got a way to go. But
That's outstanding. That's outstanding.
Just want to thank everybody in this room, and health and literacy are totally interconnected. Appreciate what you read in the proclamation, Mary Beth. But this couldn't be near or dear to my heart personally, and to my belief that the American dream rests on our ability to collectively get together and solve this. So everybody up there has made a big difference, and just truly, truly from the bottom of our hearts, we're really happy to be here and you all doing a proclamation.
Well,
Thank you.
We appreciate everything you've done, and we will do everything we can to take care of our youngest citizens, too.
You're all moonshot leaders for issuing the proclamation to honor you for being that.
Yeah, I think we will.
Did you want to get a picture with you guys here? And okay.
Thank you.
Hey, Marie, how you doing?
Oh.
Marie. Marie.
Strings of all my things.
Let me make sure we're right. We do have another one. That's the closing document. There's only one, right?
Yes.
Okay, this is a proclamation of March 2024 as a month celebrating the Older Americans Act nutrition program. So we're going from our youngest to our seniors. I like that. Okay, whereas and Liz is here to acknowledge this. Whereas on March 22nd, 1972, President Nixon signed into law a measure that amended the Older Americans Act of 1965 to include a national nutrition program for individuals 60 years and older. Whereas over 50 years, this landmark law has helped to fund community-based organizations like Meals on Wheels, and it is still the only federal program designed specifically to meet the nutritional and social needs of older adults. Whereas each year, Meals on Wheels programs from across the country join together for the March for Meals awareness campaign to celebrate its success and garner the support needed to ensure these critical programs can continue to address food insecurity and malnutrition, combat social isolation, enable independence, and improve health for years to come. Whereas Meals on Wheels programs, both congregate and home delivered in Indian River County, have served our communities admirably for over 50 years in Indian River County, and in the past year have provided 106,980 meals to 829 clients. Whereas volunteers for Meals on Wheels programs in Indian River County are the backbone of the program, and in the past year, 236 individuals volunteered a total of 18,866 hours, delivering nutritious meals to seniors and individuals with disabilities who are at significant risk of hunger and isolation, but also carrying concern and attention to their welfare. And whereas Meals on Wheels programs in Indian River County provide nutritious meals to seniors throughout the Indian River County that help them maintain their health and independence, thereby helping to prevent unnecessary falls, hospitalizations, and/or premature institutionalization. And whereas Meals on Wheels programs provide a powerful opportunity for social connection for millions of seniors who help combat the negative health effects and economic consequences of loneliness and isolation. And whereas Meals on Wheels programs deserve recognition for the heroic contributions and essential services they have provided and will continue to provide to local communities, our state, and our nation. Whereas the senior population is increasing substantially, and action is needed now to support local Meals on Wheels programs through federal, state, and local funding, volunteering, donations, and raising awareness to ensure these vital services can continue to be delivered for years to come. Now therefore be it proclaimed by the Indian River County Hospital District that March 2024 is a month celebrating the Older Americans Act nutrition program, and we urge every community member to take this month to honor Meals on Wheels programs, the seniors they serve, and the volunteers who care for them. Our recognition of and involvement in the national celebration can enrich our entire community and help combat senior hunger and isolation in America, and we're proud to be part of supporting Meals on Wheels.
Just a very brief thank you, not only for the recognition today of the importance of this nutrition program, but for the district's ongoing support of Meals on Wheels and all that we're able to do for our seniors as a result. We really appreciate y'all.
Thank you. We appreciate everything that you do as well. You can do that. Can you get everybody? Get in.
Okay, good. Thank you.
All right, thank you. Thank you.
These 100-pound chairs.
Okay, one more thing I wanted to talk about, and that is I had the opportunity this morning to go visit the command center of the Hospital at Home program that Cleveland Clinic is doing, which is in the 777 building. It's really fascinating, and they are serving not only Indian River County people, but Martin County people there too. The number of nurses that they have, the setup that they've got. And Dr. Rothman, I don't know if you know Dr. Rothman, but he's very impressive, and he's the one who's managing this. They are the first in any of the communities to be able to do this. They're the first at Cleveland Clinic. They've had calls from Mayo and Yale and everybody else to come see what it is they're doing. I would highly suggest, and Rick was very supportive, of having the rest of the trustees come and go through the command center and see what they're doing and what the outcome is. People are better off at home than they are laying in a bed in a hospital. And they're getting better quicker, and it's just seems like this is the wave of the future. And anyway, Frank, I guess I would ask if any of the trustees are interested in doing that. They're doing tours on Thursdays mornings and stuff, and they would be happy to take anybody else around.
Indeed, I think that would be great. Because this is such a, I think, big part of the overall solution of the future of healthcare in our county and nationally. I had attended a conference 6 weeks ago on this very topic to look at how this is being handled nationally. And I know that Cleveland Clinic has been a leader in this, but this is a big part of our future solution, along with mobile, virtual, and several other things, to make sure we provide access to healthcare services for folks in this county. You're exactly right, and the data will show that folks heal better at home. So I think it's a great, I think it's a great option.
Well, it was very interesting to watch the nurses interact. Patients can contact them at any time, and they monitor, all of their vitals, and they talk about what they need. But, patients are up and dressed and talking. And I said, well, what about people that are technically challenged, and older, because we have a lot of older people. And he showed me what it is that they get, and it's a button that you push. Even I could do that, so it really is. So anyways, I just wanted to bring that up, and if you're interested, let Frank know, and he can arrange for you to go see the command center. Okay, district council report, Robert?
Sure. I am not Jennifer, as my name tag says, but she's online. I'm Rob, by the way. We've responded to questions from trustees as they've arisen pertaining to the various matters the district is handling at the time. We continue to review the annual deadlines and deliverables due to the district under beliefs with Indian River Cleveland Clinic, and have responded with questions as they arise. We also have corresponded with Cleveland Clinic Council confirming deliverables and due dates. And next week, we are meeting with Executive Director Isley to go over these deliverables and what they sent us. We've also entered, as you know, the district has entered into a sales agreement regarding the hospice house parcel for a fair market value price of $3.8 million, buy-in between the Visiting Nurses Association and the district. This board approved the contract for sale and purchase, and the contract was entered into following the November 2023 board meeting. Due diligence is underway for the purchaser, and a closing date for next month is currently set. At today's meeting, the trustees will vote on a resolution authorizing Chairman Cunningham to execute all closing documents relating to the sale. Next, the Florida Association of Special Districts, of which we are a member, has created a 4-hour ethics training course for compliance with the new state ethics training laws for elected officials. Such training must be completed by each trustee by the end of the year, and we'll be monitoring that. Next, we have initiated the due diligence process to explore the feasibility of putting in an offer for the purchase of 2 properties in Vero Beach owned by the Children's Home Society for future detox and sober living facility in our community for women. Trustee Deagle held a meeting with Executive Director Isley and myself on March 7th, 2024 to discuss next steps. And finally, we drafted and sent to the trustees suggested revisions to the district's bylaws. And at yesterday's chairman's meeting, the trustees voted to approve these revised bylaws. In brief, the revisions ensured consistent use of defined terms throughout, streamlined certain sections, and clarified the ability of trustees and members of the public to comment on issues before the trustees. And that's the council report.
Thank you. I did just want to add one more thing. We do need to be out of here around by 6 o'clock. So, and we have a lot on the plate. So if anybody that's presenting, if you can just run through it, that would be great, okay? Not that we're not interested, but,
I wasn't too long, was I?
no, you were fine. Okay, financial statement, Michael.
All right, 5 months into the fiscal year, I'm once again pleased to report that the hospital district's financial condition continues to be very sound. As evidenced in the investment in cash report that you received, that's the last page of the financials, the district has thus far received 87% of our budgeted tax revenue. I look back, that's just slightly behind tax revenue payments for last fiscal year. That's not anything to worry about. It's just based on when people are making payments. And again, 5 months in, we're at 87%. On the expense side, the report shows program expenses are $122,368 under budget for the month of February, and just about $800,000 under budget year-to-date. Administrative expenses were over budget approximately $98,000 and over budget by approximately $202,000 for the year. And as noted in the report, the monthly overage is partly due to the fact there was a lump sum payment for largely increased liability insurance premium. I'm assuming as well, we probably save money by paying it in a lump sum versus breaking it up. Secondly, we also had a payment for our audit. That doesn't come free. I don't see Kip, but, you know, he's... Also, there were significant maintenance expenses related to the Gifford Health Center. I'd like to ask you now to turn to the last 4 pages of the stapled financial report in your packet. The last page of the packet is the investment and cash report that I referred to a minute ago. This is the report that's prepared by Mr. Isley, and it's a fantastic summary overview of the revenue and investment side of our finances. This is the 3rd month you've seen this report, and it will continue to be a part of your monthly meeting packets. It's very self-explanatory. I've kind of walked through it at least twice, if not 3 times, so I'm not going to do that today. The 3 pages ahead of that report is new, and it's in response to the fact that there were questions raised at last month's board meeting. I told you that I would create a spreadsheet which focuses on the district's program and administrative expenses and would show a year-to-date expenses versus the approved budget. And that is this spreadsheet, which will also now continue to be part of your monthly meeting packets. Let me walk you through it quickly. If you'd please turn to the first page of that new report. The first box, and again, this particular report, well, I say this, don't ad-lib, read. I'll get out of here quicker. The first boxed column shows the approved budget for all programs and agencies and our administrative costs. The middle 2 columns, show expenses through January and the percentage of those expenses on January 31st against the budget. And the 2 columns to the right do the same for this month's expenses. I don't think I'll continue to have 2 months there. I think what I'll do is maybe have a column fundamentally focusing on the month that we're in. I'll play with that when I reformat it, but it will be easy to do. The program expenses take the first 2.5 pages. They're the bulk of our budget. And if you actually went to the 3rd page now of this report, you'll see following program are the administrative expenses. And on that 3rd page, you'll also see at the end of the program expense section, its totals. And below that, you'll see the administrative expenses with its totals and then a total for all expenses. Like the individual programs and agencies and line items that we fund, you'll also see how the overall year-to-date expenses look as a percentage of budget. And just for a point of comparison, the very last line will show you, as this does, where total expenses were at this point last year, again, as a percentage. It's not my intent to negate a review of the actual financials that are always provided to you, but I believe, cutting to the chase, these two reports, the one that Mr. Isley pulls together and this new expense spreadsheet, will do a very appropriate job in presenting financial data in a format that makes it easier for everyone to get their heads around. We'll always take questions, obviously. As to the actual financial data in the report, 5 months in, based on an even, 1/12 schedule, time the number of months we're in the year, total expenses would be, if normal, at about 42%. And by the way, I put that at the top of each column, the header. I'll always put what it might be, what it should be if they were getting 1/12 times X number of months. For our programs, in this 5th month, you'll see that some are behind the benchmark, some are ahead. You'll note a couple at 0 as well. I thought I'd reference those because they stand out and they were significant amounts of money. That's over $500 and some thousand dollars, $560,000, I think. And they're both the LIP is what it says, and it stands for the Low Income Pool. That's tied to Treasure Coast Community Health and Whole Family Health. I raised the issue, Kate said, we've usually been invoiced. By now, it's late, she's gonna look into that, but that's why it's at 0. Skip that. Relative to program funding, I don't really think there are any major issues. As I said, some ahead, some behind. But we now have a tool where we can track carefully, and as we get a little farther into the year, we can make a determination that they still seem strange, or they're way ahead, or they're way behind, and we'll make inquiries as and when and if issues arise. With regard to the district's administrative expenses, the particular numbers, you'll see there are 3 items that are already exceeding the total budget. Those are the Gifford Health Center maintenance, insurance, which I've already spoken to, dues, subscriptions, and education. That's at 180%. Again, I've talked to staff, we've looked at it. I've already explained in my earlier comments about the liability insurance, which has driven that high. I don't think there's anything there that we should be concerned about. Again, a couple of those instances we're prepaying for the whole year, and they're all showing now. But they are exceeding what the total budget was. Bottom line, total expenses 5 months in are at 36.8%. Total admin expenses are at 58.9%, and combined those expenses are at 38.2% of budget, which can be compared to the 5th month mark from last fiscal year, which is that last bit. Last year we were at 37.6, so we're tracking pretty close. I've rambled a little too much, but that concludes my report. But I'd be happy to answer any particular questions that you might have.
So, Michael, I have a question, because I think a majority of our programs that we fund are 1 and 1/12, but we also do a lot of fee-for-service,
Exactly.
which is dependent on volume, right? So you would expect
There are
those to be-
deviations, yeah,
Okay.
exactly.
All right.
I'm flashing back to last March, and Remy is here. We had budgeted, and it took them a while to get ramped up. So, we've already drilled down on some things, is why there's a deviation.
Just a question on, for next month, will you be having the 2 columns, will it be 5 months and 6 months then? Is that what your intention is, or?
I was
why are you having
thinking,
2 columns?
I can do that if you like this format, I can always have the last 2 months. I probably was just gonna focus on the
The current one, that's what I
one.
would say too.
Yeah,
Exactly, I just wanted to.
I did this because I used the last month's statement to set up the format, since it was there, and then I just added this month's, but I will tweak it backwards.
Thank you for this. This is
like it.
wonderful. This
Well,
gives me a really good, clear picture of where we're at with everyone and as a whole. So great job.
I didn't say, but I did not include, it's my choice, I don't think it's necessary, the non-cash depreciation expenses. They're in the finances, they're in the statement, you can see that, but these are the things that we focus most on, which are the actual program and admin costs.
Yeah. Thank you. This is much easier to understand.
You're still gonna get the full statement.
That's great.
so you feel free.
Thank you. Any other questions for Michael? Okay. Executive Director report. Frank?
Hi, everyone. Just a follow-up to our financials. One of the things we had talked about in the prior couple meetings was just coming up with an estimation of what our interest income would look like for our fiscal year. And I just did want to talk to that for a second. So if you saw the news yesterday, you saw that the Fed they held rates current for the month of March. You know, whether or not the Fed will decrease the federal funds rate this year is yet to be seen based on inflation. However, the fact that the rate is kept where it's at is advantageous to us because our Treasury investments are doing quite well. So when I look ahead, let's assume that there's not going to be a material federal funds rate decrease. We're looking at an interest income this year about $650,000 for our fiscal year. Now, that's assuming that the Fed doesn't come with some, crazy rate decreases that affect our Treasury investments, but, that's yet to be seen. But that's what we're on track for as of this month. So moving into some of the items on my report, first thing I just wanted to mention is I had a really neat experience with Meals on Wheels, and I had a chance to go on a ride-along with one of the longtime Meals on Wheels folks. Fantastic gentleman who had worked for UPS or FedEx for some number of years, so he was an efficiency expert with route planning and that sort of thing. Anyhow, but I just wanted, I didn't know, and I don't know that everyone knows all the benefits of this program. Not only is it the targeted nutrition, because the same meal is not given to everyone. To some degree, they have nutritionists who plan out to make sure that the recipient is getting the proper meal for them, number one. Number two is the well check aspect of it. And being able to check on the folks and make sure that they're doing okay, and if they're not doing okay, then intervening there, not medically, but taking the next step to make sure that they get the help they need. And then, well, I didn't have a chance to experience it, but Karen did mention it. Was the social aspect is there's an option for folks with Meals on Wheels to meet up at some centralized place and have a group interaction. So it just, the program just seems fantastic, having a chance to experience it firsthand. So I thought that was great. So I want to start off with a follow-up item, a mobile response team. This is something we had been working with New Horizons on. And if you recall, Indian River County had limited hours for our mobile response team. So the hours that we've had for some time have been 8 a.m. to 5 p.m. And if you remember, this is the service that is, the whole goal of this is to intervene as quickly as we can with the right level of service to de-escalate a mental health crisis. And it's what's best and safest for the client, for the family, and for law enforcement and the therapist to intervene. So initially, we had the service in this county for some time from 8 a.m. to 5 p.m. What I was asked to do was work with New Horizons and our team here locally. The ideal scenario is to extend this to 24 hours a day. As of a couple weeks ago, I'm happy to report that New Horizons has made some great progress in this, where we have coverage now from 7 a.m. to 11 p.m. And the last shift we're looking to cover is 11 to 7. But a lot of these crises happen in the evening to early morning. So it's important that we're able to, close the gap on the shift that's going to be overnight, because early evening, morning hours are the peak hours for this sort of thing. But New Horizons team seems like they're making some great forward progress. So far, so good. So this would be a great benefit to our community. So we're making some progress there. Second thing I just wanted to mention, Dawn Carboni, who does our internal audit and is managing our performance review. While she's not here today, she's on vacation. She had given a report yesterday, but I just wanted to mention a couple things about that. We had received our draft performance review. We did a thorough internal review. We had questions from that internal review, and we had engaged with our accounting team, BJM, to review that and have those questions answered. asked them to do a little bit more digging in a couple different areas. And so I think where we're currently sitting is, I think we have a very solid product for our draft and our final submission to the state. We will have that back, and they will be here for our April meeting and be available to answer any questions that the trustees may have. But I think that our team has done a fantastic job with putting together a great product. Our consultant, BGM, has been great to work with. And I think what we're going to submit is going to be a very solid report, very accurate report, and very positive report. So, and that's not due till June, so we have a little time. Next item is a follow-up item, Beyond SNAP. I've asked Caitlin to give an update on that. We initiated that program in February, and I'd just like you to give a status update, if you could, please, Caitlin.
Yeah, so officially we started in, closer. Officially we started in February, although we didn't really start, I would say, until mid-February, so the initial numbers weren't really a lot since they hadn't even purchased stuff yet. So it looks like they helped one person in February, because it was like the last week of February, and then from looking at the portal, I saw another 2 people so far for March. We're having them log every person into our portal so that we can track every visit. It says like the date that they received the services. So we're gonna try and use that to get the data from them. And then, what else? Yeah, so they submitted 1 invoice. We're gonna get like a list of everything that they've purchased as well, so we can track what products are being used more versus, more or less, so we can see what's actually helpful. Maybe we can change things up after a couple months, see what exactly people are needing. Yeah, that's about it for
The only
that.
other thing I would ask is if people are asking for something else too.
We should make note of that.
Yeah. see
Well,
if-
Caitlin's in touch with Wendy over there on a regular basis,
Yeah,
so.
yeah, so I can reach out to Wendy and see if there's something that people are needing that we didn't include in the original list of.
Yeah, I'm just, if
6
people are
items.
saying, well, I got this, but you have this, it would just be interesting for us to know that.
Right,
Yeah.
because initially, we identified these 6 essential items to healthcare. And right, and this is a pilot project, so we're gonna learn a lot over the next few months.
How many did we project a month?
I'm not,
Did we-
it was definitely higher than, 3,
Right,
but
I was
it's
just
the
wondering
brand
what
new.
was holding them from bringing those people to the program?
Well, let me say that the initial projection was, I believe, 100 items per month, and that's what we based the pro forma on. Perhaps it's just, it's awareness, it's launching the new program. I think it's part of the discovery of what a pilot is, which we'll surely uncover in the next 4 months, 5 months.
I think it's also gonna be dependent on each individual case. I mean, one person coming in that's single is only gonna need maybe a toothbrush and some toilet paper, but then a family of 5 is gonna need significantly more. So we'll have to kind of see what ends up happening with that.
So we would need a report on the number of products rather than
Yes.
in addition to the
Yep.
number of persons.
So we're having them give receipts and invoices that have all the items that they're giving out. So we're gonna have a total for every month of which products they're giving out.
Right, and I think it's important that we record both, and that is the plan. And again, awareness is a part of this program too, which
And they
being aware.
shouldn't hesitate. I mean, in one respect, they might worry about everybody trying to take advantage. I mean, the reality is, you got to get the word out there, and there'll be some sort of screening. That's part of the process. So I hope nobody's holding back on that.
Yeah.
Thank you very much, Caitlin. I appreciate that. So why don't you jump into the next topic I was just going to mention. So the next one is a follow-up item as well. I just wanted to provide an update on an impact campaign. Caitlin has been working with Ironside and, doing a great job there. So why don't you give an update, please?
Yep, so we got the impact report back from Ironside yesterday, end of day. So we're gonna go ahead and review that, finalize it, hopefully have that out by next week, I would hope. And then they've told us that the website will be pretty much finished next week as well. So we're gonna hopefully have everything finalized and done next week. So.
Right, so we have our websites in the test environment right now, so we're clicking through it now and seeing what makes sense to, add, delete, modify. But we're in good shape there. We'll be going live making that site live at some point shortly over the next week or so. And the impact report will be our annual report. From now on, what we've decided is, a lot of the reports that we've seen, the annual reports put out by a lot of our nonprofits, they're digital. So this will be digital as well. And it'll be something that, you know, we can email. It's just it's a probably better way to deliver content. And we will have that out next week indeed. All right, thank you, Caitlin. And I'm gonna stop there. And if there's any questions, please ask. If not, thank you.
Okay, we'll move into our funded agencies report. And Carrie, welcome back.
Long time no see.
Long time no see.
I do just want to acknowledge, we have two board members here tonight. Ann Posey is our vice chair, and Wilfred Hart serves on our board of directors. I promised to be brief tonight. I did call staff a month or so ago and wanted to just the opportunity to briefly talk to you a little bit about the way we're using the data and outcomes manager position and how that's really changing the way we collect, track, discuss our data, and make decisions and share our data. And so Kylie's going to do a little bit of that with you on a piece of the 6-month report. But I wanted to share, too, the bigger picture on how we're assisting the community. And so as time would have it, yesterday we had the opportunity to talk to you about what we're doing in prevention and the prevention data. But I wanted to make sure you were aware that we are leading up our community's opioid substance use behavioral health needs assessment. And so we are underway with that, and I thought it was important that you just knew that we're going to be working and collecting data in that space. We started with focus groups, and it was really important that we heard from the people with lived experience. We can't say we know what to do with funding or what we need the most if we don't hear from the people who've been struggling. So we did focus groups. We had, Kylie, help me with number, 120?
We had 110.
110 participants in our focus groups. And those focus groups are going to inform a community-wide survey. We'll be asking the community to help us get a much larger sample on that. But we focused on the people with lived experience, their loved ones, direct service providers. We invited some community leaders for a systems perspective and some law enforcement first responders perspective. And so that will be coming, and then we're going to have that kind of on a dashboard. And that will allow our community to have real-time data. We can, semi-real-time data, but it won't be a snapshot in time. This will be an ongoing needs assessment that we can continue to collect data on, which I think will help us. As we were talking yesterday about having the community organized around prevention and having an action plan and a conversation, we'll be able to do the same when it comes to substance use disorders and behavioral health disorders. Give us the ability to really make community-wide goals and objectives, use joint planning and decision-making, and leverage all of our resources. And so that's where we're at with data and how this position's really been helping us. So we thank you so much for that. And I will let Kylie.
Yes. So one of the things that we have been able to do in our position, in my position really, is you have the 6-month report in front of you, but one of the new things that we are exploring is how do we become transparent with our data and share that with the community. So one of the things that I've been working very diligently on is learning how to make interactive dashboards. So I am going to sit down.
Heather, can you just share your background for the record?
Yes. So my name is Kylie Motiwala. I have an MPH in epidemiology. So I have a lot of research experience with epidemiology, data, outcomes, and program evaluation. I've been working in this county for the last 5 years. Get a lot of my work experience from the prevention side, doing tobacco control and advocacy. And then also for the last year, I was heading up the Communities That Care effort. So what you have here on the screen is our dashboard for our redirect program. So the 6-month report that we turned in, I have created an interactive dashboard, and what's really unique about this is it's really going to be able to guide not only our organizational decisions, but be that transparent component for the community. So the cool thing about this is I am able to break down demographics and see of our male population what their age range was, what their racial or ethnic background was, where they lived, who they were referred by. And so this really is going to kind of navigate how we are doing work in our space. And we do have it where we can even track our outcomes. So these are some common outcomes that we use to track our redirect program. And same thing, if I want to see by program, that's how our kids who were referred by civil citation or tobacco citation did. Same with civil citation. I can break it down by age if I only want to see how our 13-year-olds did. So really just trying to expand what we are offering and how we can be transparent and really communicate these outcomes.
This gets me excited.
Yeah, okay.
Really.
All right.
And I will say for me too, and then it's really, I feel confident too in the quality of the data that we're reporting out. And Kylie is able to run statistical analyses in-house so that we know the results are statistically significant. And God forbid if they're not, then we're sitting back at the table to take a look at what needs to change in that program. So I'm super excited and very appreciative of that. And I see the ability for us to build the bridge in the community for what we're doing in prevention, and now with the opportunity with the opioid substance use needs assessment to really do some community-wide goals and planning.
Well, just go the zip code.
I thought that was
And I figured it was going to get your attention because the map, Mary Beth a few months ago brought a map in regarding the mortality rates within our county by the census. And they don't use zip codes. I'm not sure what they're, but there's a 12-year spread in our community. In Little Indian River County, depending on where you're born, you're going to live 12 years less or more than your brother down the street.
Different zip code.
And I'm kind of curious as to where the zip code map aligns with the other map, and probably consistently.
Well, I've been a big advocate for South County, too.
Mm-hmm.
And the attention, and I'm looking here, and I have 32962.
And this is the kind of
Pretty
plan,
big piece.
right? And this is the sort of information in terms of helping other local units of local government with their planning and committing resources, because it's data-driven.
Yes.
It's neutral in however many ways you want to try and criticize an approach to dealing with public policy, and it's real. Thank you.
Yes. This is really exciting. I mean,
Did you have to develop this software, or is this something that exists that, why isn't every county in the state using it so that we can be tracking?
Yeah, so this is the Microsoft Power BI software. So with a Microsoft license, you can access this program, and then there's premium features.
Yeah, but the point, yeah,
But you developed it, basically, out of
Well, so
Microsoft.
I've put in all the data to make
Right.
this happen, which
Okay.
is a process.
but this is what we want. When I had met with Kylie and Carrie, I don't know, a couple weeks ago, I had a discussion. This is the type of dashboard that I want for the district.
Yeah.
Multiple levels, there's multiple layers, multiple things, but by zip code. So this is kind of, we're looking into our future on what we're going to be referring to as a dashboard on a quarterly basis.
You're worth the money, Kylie.
And the final side of that, when we look at this dashboard, so part of that needs assessment, we will have a dashboard like that for the needs assessment and the results that we're collecting on that. And then Kylie comes in and again, really transforming the way that we as an organization are looking at collecting and talking about our data. And so quarterly, she's presenting to the board. They have that nice visual, and Kylie's very talented in presenting the data in an understandable, easy to digest way.
And Frank, the only caution I would say when you say we're going to develop this too is when so many people start developing, and then if data doesn't agree, data becomes unimportant. And so we just got to make sure that we're in line with, using the data or using the information, and maybe she can feed into something
Exactly.
instead of our creating anything.
And as I settle here in the community and interact with so many different organizations and understand, just at the beginning of understanding what everyone's capability is, that's one thing I think is paramount, especially as the hospital district, is that the data that we're going to use, I want to be consistent with the data with every other organization. We should have one set of data points that we're all sharing. We should have that level of collaboration.
Otherwise, the validity of it goes away.
Yeah.
Share this with, you probably have, Chiako over at.
So, and I will say, so I have reached out to Chiaka, and she'll be able to
Yeah.
embed the
Exactly.
dashboard that
Exactly.
we have for the
That's
needs
exactly what I
assessment
was thinking.
through
Yep.
the indicators.
Yep.
Yes.
Good move.
Nice.
Do you want me to speak on any of the questions that were sent to me, or I know I've taken up a lot of time? I can update you on the adolescent treatment program that has been slow to start, and I've been communicating with staff that answering the questions that were put forth to us, really, the answer to the question is we learned about the landscape that has changed in hiring for behavioral health. And so, starting adolescent treatment did not go as planned. We learned a whole lot, and in screening and interviewing people, we had so few applicants, and the applicants we screened, they wanted telehealth, remote work. Click when we said no. They did not want evening hours, and I thought we were giving a generous salary, and what we learned is we needed to up all of our clinicians' salaries to make sure that we keep them when we started to see what was out there. And but I am happy to say we did extend an offer, and it was accepted yesterday. So we should be hitting the ground running. We've just been waiting to put the person in the seat. So hopefully you'll be seeing some data and outcomes on that program soon.
Good.
Anything else for me?
You guys do really good work
Thank
and
you.
much needed work, so
Well,
thank
we
you.
appreciate the support that we get from the hospital district.
What is MAT? MAT in jail. When I said MAT, didn't help.
Medically assisted treatment, so
Thank
it's using
you.
the medications to help people with substance use disorders in combination with comprehensive counseling.
Thank you.
And thank you, Vicky's back there. Vicky's we don't provide the medical services, we partner with TCCH for
Right.
the medications and the medical needs of our clients.
You got some good board members there, too. Thank you. No, thank you, Carrie. Appreciate it.
Thank you.
Thanks, guys.
Next up, we've got TC Homeless Services. Ramey? Good to see you, Wilford.
This podium is too short. Good afternoon. Thank you very much for your partnership. It's interesting that I want to ditto everything that she just got through saying about the reports. Interesting enough that you bring up data. Frank and I had a conversation earlier today. Data is something that our organization has taken a pivotal change with, and using that data to predict individuals' homeless status in our community by using our data management system to help us learn how to impact people's lives. And so by doing this specific program, the numbers we have are small because we got behind in our startup as well. However, we're seeing that successes already. So the things I want to point out, we have had 17 individuals we've served, over 180, almost 180 specific services, whether it's assistance from a community service agency, financial navigation, legal navigation, healthcare navigation. It could be assistance with SOAR or SNAP or other public benefits that they may be eligible for. Most importantly, case management. But one of the things that we want to share with you, and you're the first people to receive this information, we did our homeless count in January, on January the 25th. As I said in a public meeting before, I believed that we were going to have a decrease in our homeless count, and in fact we did. We did simply because we changed how our organization was working with street homeless individuals. And keep in mind, there's a couple of different homeless definitions across the system here, but ours is specifically those who are on the streets in places not meant for human habitation, living in their car, okay? That is our strictly homeless definition for our organization and how we serve. In 2025, or in 2024, we had 225 adults and children living on the streets. 154 adults, 71 children. That's a 34% decrease from the year before, okay? With that, we had 75 that were sheltered in that process. So we had 150 that were unsheltered for a total of 225. With that, 32% of the children were unsheltered. That means 23 children in our county were living on the streets. And a little bit more information, which is interesting for me, is that we had 154 adults. Out of those 154, 42 identified of having a serious mental illness. They self-reported. This is how they self-report to us. 21 had a substance use disorder. 3 HIV/AIDS. 16 domestic violence. So that's 82 out of the 154. So 53% of the individuals that we counted had some form of a diagnosis or a challenge that they are experiencing as being homeless in our community. So that's some very strong data points. By using the data, I have a meeting with our data company that hosts our data for us, and that's called Ecovia. And they're a company that manages many communities all across the country. I met with them 2 weeks ago, and he's going to be back in town to talk about how we can pull data from utility companies and other substance abuse, get data from your organization and use it as a community resource to do predictive analytics. These were things I worked on when I was at the VA, so this is like really, this gets me going. So I wanted to share that with you because it is something that we will be moving forward with in the community, and pulling more community providers together to obtain their data so we can use it as a community resource to help us as we help citizens in our community. So, not necessarily as a part of what we're doing for funding for this program, but I wanted you to be aware of that's part of where we are. If you looked at our report, I think one of the last questions you asked was what, sorry, too many pages here, because I had a PowerPoint myself. Was just beginning it, we are going to be investing in an AI system to predict and prevent homelessness. That's what I want us to work forward with all of the data to be a data-driven leader in the community. Because I know we need it across all 3 counties that we serve. I want to focus on large-scale solutions and increased collaborations, not only with your organizations, but the other organizations in the community. We will be rebranding in 2025 because we'll be 25 years old. And most importantly, our final component is we are investing all of our resources in a strong focus on social determinants of health. That is how I want our organization to invest in our communities that we serve. Any specific questions? Sorry, I'm losing my voice. It's just this county alone, yes, sir.
Secondly, you mentioned people with mental health issues. What about physical health issues? Do we require more use of equipment for medical means?
That's not a specific question that we ask when we do the count. There's only those 4 items that are very specific for us because that's a data set that we track because it's a HUD-required data set.
Very good.
If I could just add one thing in support of, just not just Ramey, but a lot of the organizations that we're working with the hospital district is there's this theme that you're hearing and you're going to be hearing. I mean, Carrie had mentioned it yesterday with the executive roundtable, and Ramey just mentioned it today. And we've talked about it a little bit before at our meetings, is not just a focus on, okay, do we have enough providers? Do we have enough services? How do we solve these problems? But actually trying to get to the root cause, identification, prevention of these issues. Mm-hmm. So, how can we leverage technology? How can we leverage data? How can we leverage communication between all the organizations in the district to really be forward thinking? And how can we prevent these things? Let's figure out the root cause. Let's focus on prevention. Not just solving the problem, but solving the problem through identification and prevention. And as we've talked about that executive roundtable, I mean, this is what I think a big part of what we can do together in our county to really make a difference for health and well-being for the future.
Absolutely.
And are you going to tell us a little bit about the respite centers, that update on that yet today or another time?
Pardon?
They just said they had 17.
Oh, I missed the 17.
Yes.
In both of the men and women?
The written report that you have
Yeah.
is about the respite.
Oh, I know that. I can see that's where I'm referring to. And are you using a boarding house model? Is that the same as what you refer to as your in-house model of men and women? And
If that's how you want to refer to it, that's good, yeah.
Okay.
We call it rapid resolution respite, so.
Any other questions for Remy? Thank you.
Thank you.
Yep, thank you. Okay, any unfinished business? We'll move into new business, and Kip, you're up with the audit and agreed upon procedures.
Hello, everybody.
How are you?
So the exciting part of the year, we get to review the year-end audit results. So we have a couple of reports that we've presented, and I'll try to go through relatively briefly, but I will highlight them. We did meet last month with the Finance Committee and went through in pretty good depth the two reports, so I'll spare all the time. But ask any questions that you might as we go through. So we'll work through the audited financial statements as of your year-end, September 30 first. And in that report, you'll pass through the audit opinion, which is several pages of boilerplate discussion about essentially unmodified, fairly presented language, the highest level of audit report that you can attach to your financial statements. So it's a good thing. We'll move into the first primary section of the report, which is the management's discussion and analysis, and that presents your ability as the management team to present your analysis of the financial results. And I'll highlight a few things in here as we go through those pages. So on page 4, table 1 sets the stage for your revenue base. And you can see that for the fiscal year ended September 30, the total property values in the county were some $23.4 billion, up from $20.6 billion in the prior year, or about a 13% increase, 13.5% increase. Knowing that and knowing your financial position and budgeting process, you took a look at your financial needs and you reduced your millage rate from 71.44 down to 51.10. That was about a 28.5% decrease in your millage rate. So you'll see that in the financial information as we proceed through the report, but that demonstrates that you reacted to the large increase in the property values, adjusted your millage, and established a revenue base that worked for the district. The report continues through some strategic analysis that you wanted to highlight for the stakeholders and readers. But I'd like to move to page 9 that presents our next two financial tables, Table 3 and Table 4. Table 3 presents your balance sheet, if you will, the statement of position, net position. Total assets at the end of the year were some $11,941,000, down slightly, about $465,000 from the prior year at $12,000,004. Mostly that relates to some non-financial assets, the lease accounting and physical asset that you account for, but also with some receivables that declined during the period. Liabilities that support those assets, $1,003,000 compared to $1,002,000, down just slightly, in essence, from the lease accounting. But with the increase in the program obligations that you have on a monthly basis, the payables were actually increased in comparison to the prior year. So the net of those two categories represents the equity in the organization, or the net position, and stood at $10.6 million at the end of the year compared to $11.2 million in the prior year. Down about $500,000, and we'll see that in the next table. but in essence presents a very strong financial position for the district with right at about $9.4 million in unrestricted net position available to support operations. Table 4 presents the revenues and the expenses, and you can see total revenues $11.4 million for the year, down from the $14.1. Again, you had planned for a decrease in your budget and in essence utilizing some of the reserves that you had built up during the prior periods, and so your revenue your gross revenues did drop for the year. The operating expenses stood at just at $12.5 million, up from the $10,180,000 in the prior year. And again, you had planned an increase in your program expenses, and you can see that in the first line item. Total indigent care program funding, $11.4 million, up from the $9.1 million in the prior year. As was pointed out earlier, with the investment income earnings that you've generated with the increase in the interest rates and maximizing the utilization of your cash positions, you generated $543,000 in investment earnings compared to just $92,000 in the prior year. So that's really making a positive impact in support of your budget. So overall, you reduced your net position by the $552,000 during the year. There's additional discussion as you work through the document about some of those changes. But the next page, if you can turn to page 11, Table 5, gives you an overview of the various different agencies that you provided the indigent care and program funding for. You can see it's quite a list of a variety of different agencies and the balances in comparison to the prior year. From a budgetary standpoint, some of the agencies were a little bit less. You had actually planned to spend more in the program area, and it came in less than that, as you'll see in the next couple pages. Page 12 gives you an overview of your capital assets and debt financing. No real significant change there. However, you did have a lease modification in your office space during the summer of last year, and it caused an adjustment to the accounting for those lease assets and liabilities. So that's been updated and discussed in the bottom paragraph on the bottom of the page. And then page 13 presents your budget comparison to actual, and you can see the various different categories that you had budgeted for. Revenues were enhanced above budget, favorable variance of right at $313,000, and you can see the favorable variance on the indigent care funding had planned for some $13 million in funding, but spent $11.4 million. Overall, you had planned to work down your reserves by $2.7 million and ended up being a reduction of $552,000. So again, a favorable variance of $2,150,000 as compared to budget. The last section of the MD&A gives an opportunity for you to look in a more forward basis, looking into the future, and so you can discuss in a variety of different paragraphs there the factors that bear on your future and your plans for the upcoming fiscal year that you're currently in. So those give an insight in terms of how you see things unfolding for the upcoming year. With that, you move into the primary section of the financial statements. It, in essence, provides more detail than what I just went through. So if you wanted to review those, I'll invite you to do so, but I'll pass through that for purposes of time. It repeats a lot of it, but in essence provides more detail. And then the third section presents special reports that are required as part of the governmental reporting. The first report on internal control over financial reporting and compliance matters. Again, a couple of pages of boilerplate language, unmodified, clean report, no issues to report. And then the management letter is required by the Florida Auditor General's Office, addresses very specific items, and again, the information is provided, but no matters to report as in terms of deficiencies or issues with respect to the accounting or the financial condition that you carry for the organization. So that's essentially it. Pretty brief, quick overview, but I'm happy to answer any detailed questions about that or the audit process.
Looks like a clean audit.
It was a clean audit.
That's
Very much
good.
appreciated in terms of working through that with staff, and that went very well. I will then move into the next report, which is the agreed upon procedures report.
Let me ask one question of Frank.
Sure.
The people looking at our performance review, will they see this? And is this part of it?
They have, I don't believe, I'm not sure whether or not Dawn had sent this over to them already, but
They will see it.
They will see it. I mean, that's my question. Will they see this?
I can't speak for Dawn, but I'd be happy to get that over to them, sure.
You would have seen last year's as part of the stuff that we,
Yeah, correct.
yeah.
Correct. Yeah, they have not seen this year.
nothing wrong with showing them this.
Right.
Right.
I
Right.
mean,
Yeah, why not? Indeed. Yeah, makes sense. Yeah.
Sorry, go ahead.
Okay, so the additional work that we do for you is each year we go through and do some very detailed compliance testing on patients that you have supported throughout the agencies. And so this report covers the period ending September 30, 2022, so it's going back a little bit. However, if you go to page 1 of the report, it provides a summary overview of the agencies that we reviewed, of which there were 6 agencies, which basically are fee-based, based on the patients that you're serving as you've entered into those contracts. So it does not include the agencies for which you provide general grant-type funding. But we detail tested or compliance tested just under 400 different patients across the agencies, and the results came in very well. Out of the some 400, we came up with 9 exceptions, and I would describe those as technical exceptions, not in any way, shape, or form grievous type exceptions. For example, in terms of testing for eligibility or the proper time period for which you're providing the service, there was one patient that ended up having service provided 3 days after their eligibility period ended. So again, in the spirit of the funding, it was an exception, but it was not a grievous exception. Those are the types of exceptions that we see at this point. And there are very few across the detail that we look at. So there's an individual report for each agency. It goes into a little bit more detail about those results. And on the second page provides a financial overview of those exceptions that we provided. And I can say that for that period, with the $26,000 associated with those, one of which was the primary one, and again, it was a technical exception, that's the lowest dollar amount associated with exceptions in any period that we've been reviewing for many years. So the results are really very positive and favorable, and I would say that's indicative of a system that's working well.
That's good. That's what we want to hear.
Yeah.
Any questions for Kip? I'm sure you had questions in the finance.
We did, I mean, it's a really good discussion, and we had a lot of the right people around the table. The only thing I'd add is that we're gonna make sure that we're a little bit more ahead of the calendar next year, and everybody agrees with that, so.
Yeah, I think our plan is to meet with staff in the next month to iron out which agencies we're going to look at on the detail testing. And then, of course, when September 30 comes around, we'll be ready again.
Thank you, Kip.
Good to
Okay.
see you.
All right, thank you.
Thank you, Kip. We've got Dr. Cromer.
Do we need to take a formal action accepting the audit report, do you think? I don't know. You've done this before, not me.
Yeah, we probably should. Okay, can I hear a motion to accept the audit report?
So moved.
I would second that.
All in favor?
Aye.
Aye? Did you say aye? Okay, I can hear. Okay. Okay, thank you. Now we've got the Mental Health Association, and by the way, you had no exceptions in there.
Hi.
They're very good.
Clean audit, that's always a good
That's a good
thing
thing.
you want to hear from your
Hear, hear.
CPA, right?
It's a good thing.
I'll try to keep it brief. I have some remarks, but I'll try to chop it down for the sake of time because I know we're running a little low. Esteemed trustees, today as I stand before you, we are on the brink of a new frontier in our mission to uplift and support children and their families in Indian River County. The Mental Health Association is embarking on a monumental journey in which we are establishing the MHA Parent and Child Center. You might ask, why do we seek your support for this endeavor? I've talked about this before coming before you. I think we realize that there is a need, but I was looking at some of the statistics from the State of Mental Health in America, the 2023 stats, and it really just goes to show even more so that this center is really needed, because 62% of youth in Florida, and this is just a slice of this report, but for those who have major depressive disorders, they are not receiving any mental health treatment. And that's just a slice. That's just major depressive disorders. So when you look at that and you think, well, what's happening with adults? That's why Florida is #1 in the prevalence of mental health disorders in the country, and 45th in the delivery of mental health services to adults. So it makes a lot of sense. When you see what's happening with the kids, then it goes through their entire life, right? That's why we need this center, and that's why prevention and intervention is going to stop this problem, particularly here in Indian River County. But let us not dwell solely on the negative. In every challenge lies an opportunity, and in every child lies the potential for profound transformation. This center, this sanctuary for healing and hope, will provide prevention and intervention. It will be a place where the seeds of resilience are sown and where the bonds of family are fortified with the collaboration between the MHA, Tykes and Teens, Suncoast Mental Health, and as we look into the future, we hope to collaborate with others as we see what needs we need to fill. The stakes could not be higher, nor the cause more noble. So in the year to come, with regard to the Mental Health Association's portion of this, because we have a couple of positions that we're hoping to get funded. One is the psychiatric nurse practitioner. You have left. We have filled the gap for the most part, and we're therapy first, but we want to have some psychiatric provider there at the Parent and Child Center. We'll have Dr. Lynn Williams there for about a day and a half. And in the year to come, she'll provide approximately 288 psychiatric services. We're also going to have a full-time therapist. And I can say, as of today, we have a full caseload for this person already. It's waiting, 40 new kids, and in the year, that will total about 960 mental health services. So that's a good thing. So we expect about 20 individual therapy sessions a week with a caseload of about 40 children. But some kids are going to be seen more, some are going to be less, so this is going to be an evolving thing throughout the year. Our skill builder, who will be delivering the empirically supported Smart But Scattered program. This is a program that improves a child's executive functioning. So executive functioning is correlated with improved academic performance, a decrease in disruptive behaviors in school, and improved self-esteem, which then helps their mental health, right? In addition, we're also going to have 2 interns. We're not going to be paying them, but they're going to be supervised, so they get something out of this as well. So we train our interns, we get a little additional help. Maybe they stay in the community, maybe they stay with the MHA or they go elsewhere, but this is also a benefit. Each of the interns will see approximately 3 to 4 students per week, so that's 144 mental health services for the year. So you're talking about 1,000 sessions just with therapy. With regard to financial commitments, we do have some. We have a grant going into Indian River Community Foundation. We have some money from the Marty Fish Foundation, which is going to be supporting some resources that we need, some books and things. We spoke to Southeast Florida Behavioral Network today, and it's promising they are going to look into reallocating some of the money from the UF appropriation. So that's still in the works. I wish I had hard numbers for you, but I think that's going to pan out as well. And we've been meeting with a variety of private donors as well, so we've been getting some money coming in from that as well. So with that being said, I'm going to stop now because we do have representatives from Tykes and Teens and Suncoast, if you could come up, and we also have Angela Gazinski, who's our COO, who could answer any sort of budget, additional budget questions that you have.
Dr. Cromer, can you just explain, I think it's really helpful, or maybe perhaps someone will explain. First of all, this is a collaboration between 3 organizations. Second of all, getting back to the point I made about root cause and getting to the root cause of some of these issues, I'd like to hear a little bit about the intervening with the families, that program that we heard from Suncoast as part of this collaboration, and just maybe speak to the different elements, because when we met, the way you described it, it sounded very innovative. It seemed like it would get to the root cause of some of these issues and our focus on prevention.
Yeah, because it just isn't about a kid who needs therapy. They may need soft skills for school, et cetera. But what we have here in Tykes and Teens is infant mental health. We have with Suncoast the ability to have sort of wraparound services. I don't want to call it case management because it's diminishing that, but I'll let the 2 organizations.
Sure. So we're really pleased to be a partner in this, and we actually, what we need is space. So one of the things that we're struggling with, we're expanding rapidly in Indian River County. We have a nice little office that we're rapidly outgrowing. And when Phil and Angela talked about this, I thought, you know, wouldn't it be neat to put services that they don't do, that we do, you know, in more of a central location? So our plan and our hope is that we can shift some of our infant mental health therapy there, which I think is a natural fit. So if a family comes in with an older sibling, you know, to get services at MHA and may need infant mental health services, it's kind of a natural fit. We also have, we do have some case management, true targeted case management. So we talked about maybe shifting that person over into that space. And then we do trauma-informed care for the community. We're also a semifinalist in Impact 100, and I don't know if we'll get that Impact 100 grant. It's quite competitive, obviously. But one of the things we were proposed was parent peer support. So people with lived experience supporting families. And if we were awarded that, I think that would be a great fit. Being able to serve families not only within Tykes and Teens, but perhaps in other agencies. So anyway, that's our contribution to this collaboration. If anyone knows me, they know I'm all about collaboration. I don't like reinventing the wheel. So.
Do you have enough space at the UF site, at the old UF site?
We do, yes.
Okay, so it's sufficient space for starting and then growth?
Oh, yes. Yeah, absolutely. We've signed the lease. I've wheeled the printer over today. We're ready to go.
Hi, how are you? I'm Deborah Engel, the CEO at Suncoast Mental Health Center. I know this is the first time I'm here, so I don't know who knows about Suncoast or not, but we have been in the community for 25 years. We are a community mental health center. We do service all 4 counties, Martin, St. Lucie, Indian River, and Okeechobee. And in Indian River, we have our office right next to the high school. And long-standing relationships with everyone behind me. And one thing, not only do we have therapy, but as Phil was talking about, we have targeted case management. And through the years, we really are looking at what's going on in the community. And we know that families are suffering. There's so much going on, whether it was through COVID, with schools being shut down, whether there's just so much going on in the world right now. And, you know, parents are working, kids are coming home, you know, and trying to find stuff for them to do. So we have been talking, you know, internally, and this came about talking to Angela, looking at the expertise that Suncoast has through the case management, but really making it family services, family support services, Wellness Without Walls. And it is a program that I don't know if anyone's heard of, the Casey Foundation, but it's really about strengthening families, strengthening communities, and working together. And it is a pilot program, you know, that we want to work on. And it is part of traditional case management with the brokerage, with the linking. It is strength-based services. So it's looking at what are their strengths, how can we as a working with the family so they can improve upon their communication, their skills, knowing what's going around in the community. And it's, I have other people that can talk more about the program. I don't know kind of if everybody's read everything or not and what questions you may have, but it's really a new program. We are looking to expand it in Indian River County and also throughout the Treasure Coast. I know that there questions came about the funding. Yes, right now it is not something that is funded through any other insurance company that we have. There are other funders that I do want to speak to about the program, but this opportunity came up pretty quickly. So we put this together to present to you, to see if it's something that you will support. And we do have the case manager ready. She is bilingual, to transfer over to the family support specialist. There are trainings that will happen, obviously, working on motivational interviewing and just a whole bunch of other stuff and getting the information out there. We talked about the lack of knowing what's out there. One of the things that's so hard for families to navigate is what is going on in the system. How can they get access, lack of transportation. And it's really working so that we can be in there working with them and then be able to leave and then they can function as a family. So there's less tension, there's less fighting. They're, out there in the community giving back to the community. And it's just, I can go on forever, so I apologize.
Could we just hear a little bit about, I think it's important that, because this is different, this is something that insurance does not pay for, the aspect of this program.
Mm-hmm.
I have a few questions.
Sure. Mm-hmm.
Sorry. So I need to have a picture drawn here. So that it's a collaborative effort. You're going to be using the old UF building that you've got the address here at.
Right across from the current.
Right across the 840. Okay, and your rent. So who's taking the lead on the organizational part of it? Because I know you all do wonderful things and your impact is great. There's nothing, but who is going to be managing this whole thing?
Right. So the MAJ is the lead organization. We've signed the lease and
Okay.
we've invited the partnerships. So we've been meeting quite frequently. There'll be a lot of interdepartmental referrals. That this will really work. This is going to take off, and there's plenty of space. And another thing that I want to mention is
Who's going to be answering the phones and stuff like that? Is that MHA
we
is
have
going to be doing
front,
that?
Yes, we have front desk.
Okay,
staff.
and then you'll be calling the others in when it's appropriate? Is that how you're going to do it?
So right now, we have a collaborative effort, and yes, we've known each other for 20 years. And, we're seeing the needs on the walk-in basis with these children, with the whole family. We have had several meetings, discussed things and where the gaps are in the community, and we needed to expand our walk-in center. UF came up. We're like, if we don't take it, we can't expand our services at the walk-in center, and we had visioning with Impact 100 for this parent and child center last summer. We just didn't have the facility to do it. So timing was not on our side to really do an Impact 100 because we didn't know where we could have the programming. And then we're getting together and we're going, where are the pieces missing? When we have these families, when we have a young child come in that's having behavioral problems, they don't need a therapist, they need skill building. We are doing the skill building in the Boys and Girls Clubs, but bringing it to an outpatient basis so it could expand to the rest of the community, as well as being able to work with these other agencies more closely. We're sending over referrals, we're trying to follow up. This will be able to encompass the whole family. We may see them on a screening and go, oh gosh, they need a targeted case manager. We don't need to be, okay, let's get you a therapist and we want them to get to the appropriate services, get to them quickly, do the wraparound services. They may be in family care management and therapy.
And I don't doubt any of your services. I mean, you guys are phenomenal at what you do, and so that's not, where I'm driving home is your costs that you're asking for. So you're asking us for the $288,000, 88 going to Suncoast, and the 200, and really we're covering the cost of the whole program. Is
The
that
whole
correct?
program-
Including
The whole
the rent?
program, I submitted the budget is 444,000.
Right, okay, so then.
You know, there's a lot of overhead costs, there's support staff, especially working because we're gonna have extended hours there.
So where's the other 140,000 coming from?
So we put in money, we have Indian River Community Foundation that we're requesting $50,000. Our request was approved, so we're working on the grant right now. We have reached out to Southeast Florida Behavioral Health Network, and we applied for some, what was the funding
It
called?
was one-time, non-recurring funding.
Non-reoccurring
discretionary
funding, because we had to take this center, the landlord would not give us any room to move in February or March, so we had time to plan it. We've been paying since January, so there was no lapse for the landlord. And then we have foundation grant for computers, all that. We borrowed a copier, that's why I made Phil put it across the hallway.
And these funds that you're asking for you'll be wanting them to be reoccurring year to year because, of course.
So, you know, I think what we want to do is really build sustainability in the programming. In Hospital District, we utilize funding if we can't get the funding elsewhere. We're hoping to get some program fees. I've built a budget, so if we can have, you know, the psychiatrist or we have a licensed provider get on Blue Cross Blue Shield, we will be charging insurance. So we're really trying to get a good piece of the pie and not have to count on one payer source. But, you know, in order to get it started up and rolling, yes, we probably will request the staffing until we can get other revenues. And this parent-child center, you know, I mean, this community needs, it's going to be one of a kind. And I think, you know, with donors, it's you know, we already have donors giving us some money for it. So once we get it open, have the open house. One of the things working with other nonprofits is, okay, I have to sublease to you because my overhead is, so I've included that so that, you know, I don't have to charge Debbie or Ann because I know they need to get their programming up and running to be able to do that.
The timing of it was a bit wonky. You know, you can't get the lease without the money, and you can't get the money without the lease.
Right.
So we had to sign the lease and kind of hustle along. The money's going to come, and I'm confident that the managing entity is going to come and hopefully pay some of this rent, which is a big chunk of this. But
So to
we will
Karen's
need some
point, though, we are going through right now for next year's funding, okay? So I think what you're asking is, this is startup. And this is to get going
Right,
in
until
between.
your fiscal year
Okay.
starts, and I will be putting in a request for the Parent and Child Center for funding, but it probably won't be necessarily for the rent piece, because we may be finding out some other funding sources in the meantime.
Because we typically don't pay
That's right,
rent.
that's where I was going
And
with that. It's like,
historically,
okay, how are you gonna do this?
Historically, we got Children's Service Advisory Council, grants and stuff. Again, everything's in the timing. You know, when it's the cart, you know, before the horse. So, so we are building funding, and that's why I did want to give you the whole program funding so you can see where we want the revenue coming from, and not just count on a hospital taxing district, but to help us kind of lead this, at least for the first year, and then I may do drawdown later, or we just need to get it up and running. We need to get the staffing.
So, but,
Ann?
Teens and tykes, sorry.
Tykes and teens.
Tykes and teens, sorry.
Yes.
You will be also contributing and Suncoast too, so you're going to, because it's
So I think when you look at it, at least from Tyke's perspective, the collaborative nature, right? That to making sure people can access services, people aren't sitting on wait lists when we might have a slot. We get funding, we get very generous funding for our infant mental health program, not only from the Grand Harbor, Johns Island Community Service League, you know, we are approaching the Community Foundation, we get hospital district funding for some of our programming, you know, so it's not a cost, but I think it's a benefit.
The sublease would be a cost.
Right, so the sublease, right, by providing me space.
All for that center is what I'm saying. It's not mental health associations not gonna be picking up the bill, they'll completely.
Well, the way we
overall.
structured it is they would pick up the
Oh, okay.
rent,
Okay.
you know, in this
And the
ask,
support
so that we
staff
didn't have
and
to
the
do three
copier.
sublease, you know, all
Got
these
it. Okay.
subleases.
Let me ask about staff. In terms of the job descriptions
Yes.
submitted, I think you had 4, there may be more, I don't know, and a couple for Suncoast. Are there people there to fill those roles? I mean, we hear constantly from all of the folks
Yeah.
we're supporting that they are short-staffed and they
There
can't
are
find
today.
people, and without,
Yeah.
if they find them,
you
they
know,
can't afford them.
So skill building, we have Marty Fish funds to get 3 certified trainers in the executive functioning skills. We do plan on hiring 1. It does not need to be a master's level. People are struggling getting masters. We are not struggling, you can ask Heather, getting master's students. And we already have a licensed person that's gonna be going over there, so we just need to fill 1 more licensed person. And, you know, I think we do have good benefits and good roles that, you know, we don't feel like we're gonna have a hard time. That would be the only hard position to fill, but we're already put out feelers out there and have a few potential people. And then as for support staff, just to let you know how we kind of utilize funding, I put 1 for support staff person, and I wish 1 support staff person can really just be at that center, but, you know, we have extended hours, so we use, we're a host agency for the AARP program, so I have 2 25-hour weeks. People that are already trained to be able to help compensate for that, so we can keep the budget pretty tight. To be able to do that, but in our phone system through level 4, they donated phones, and UF left behind stuff. So we have pieced together stuff until our foundation, hopefully our foundation grant comes through. And we had some old computers. So we can make the center open. We just need that kickoff.
We've been cultivating therapists for years, so a lot of times they want to come back or they're waiting to come back. You know, it's like coming back home.
Suncoast, you've got 2 positions?
We already have one that, she works for us part-time, she wants to come full-time and
Okay.
transfer over, and the supervisor's here with us, so, yeah, we have the staff, we're just.
We have the staff. so
She's got the
people are
staff.
waiting. Yeah.
They can go
The
in.
positions we have are currently full. I will say that for licensed clinicians, that space could be filled position today, and tomorrow it might not be.
Yeah.
I mean, that market is very, very challenging, but we've been very lucky in Indian River County specifically. We've been able to maintain a full complement of staff. We're recruiting for another infant mental health therapist because we do have a wait list. And that's a little challenging to fill, but we've been lucky.
And I just kind of
In
want
this county.
to point out the psychiatric piece, because we do a drawdown with our psychiatric nurse practitioner. It's just we didn't utilize her a lot. And again, doing this, we all talk so much more, and I think Anne's pretty much at capacity because of the UF kids. So, you know, thus I'm like, oh my God, I got to turn this around. Frank knows because I gave you a different one at the beginning. That I'm like, oh gosh, we got to turn this around because we need to make sure that we can secure these kids on continuing medication for the ones that we need it. So I did, you know, ask for the 12-hour a month.
We
Barb,
could
you-
probably support a full-time, I mean, you know, probably this county could support
I'm
another
sure we could
full-time
support a lot
psychiatric
of
nurse
them.
practitioner.
Barb, you have a question?
Just going back to what Karen had asked and you answered, did you mention about the possibility of some Blue Cross Blue Shield or other insurance?
Absolutely. We were able to make a complaint and get into that market. So as long as I have a licensed person, now that we're a group, I can add them. It takes them about 2 months to credential them. The problem is getting the licensed person. We have how many therapists? And
What's the
90%
licensed
are
person?
registered interns.
Therapist?
Same for us.
Yes.
So not the nurse practitioner?
No,
So,
she's licensed.
Yeah, the nurse practitioner, yes, she can be credentialed.
So
Yes.
if we approve this money tonight, how soon would you be up and running?
run it, it's ready to go.
Yeah,
So I
we're
just
in there.
need-
We've already moved one
Yeah.
therapist over. We have the front desk
You've got a
staff.
printer.
We've got the printer.
Oh, okay, we took a print, we borrowed a printer.
The staff is not happy
We still need a
about.
foundation.
We actually are already going to start a dialectical behavioral
Yes.
therapy group. We have that group that we don't have space for, so we're
Yeah,
gonna.
we're ready to go.
And the clinical
go.
team, we met with Carrie last week because she reached out to us. I know she laughed. Right? Oh, no, yes. So, Carrie reached out to us. We all really want to work together and possibly getting some people trained for Strengthening Families program and working with, tell me, communities that care. Yes, programming. So it's kind of all coming together, and we do have collaborations, but this is going to be so strong that we're going to make sure that kids and families are taken care of.
There's a lot of enthusiasm for the program. The kids are, we take the kids over there now just so they can walk through the space, and they're so excited to get started and be in our new
And I don't
space.
know if you think about the power of having a separate space for kids. I think this is important
Yeah.
because Mental Health Association serves adults, so if you walk in currently, I used to sit on their board, but if
Right.
you walk in currently, you have a mixture of adults and kids, right? There's a lot of safety in having a
Yeah.
safe space that's only kids.
Yes.
How much
And-
square footage are you getting?
Right now, that's 3,750 square feet.
And how much will this fill?
We are full
We're
in the
full.
space. The problem with the space is we would like to make some adjustments to the space, but we're not going to for a year. We do have first right of refusal because our landlord is wanting us to build out on the space that we currently have of 2,500 square feet of our current building. It kind of gets a little complicated. So, it's kind of like we can't give you this until you do that. So we're kind of in doing both. But we do have the first right of refusal. It's getting very expensive. CAM is expensive.
And there's another
We need
added-
land.
There's another added benefit to this center as well, because we're moving some staff from the MHA walk-in clinic portion over to the PAC center. So we have more room to do things for adults, so.
Right, because we do have people that are on case assignment and drawing down hospital district funds. We have that. We just did not have the space, and also increasing adult psychiatric care with the UF closing and needing to kind of help the community with that. So we were kind of at a standstill, and I talked Phil into it, and
So,
It seems silly to ask even, but, I mean, I've been there. Is it safe in terms of passing kids from, or anybody, from one building to the other?
They won't be passing. They'll be going to their therapy appointments at the
Okay, so it's
parent-child
not like-
center. We are gonna be.
Because it's a drive-through.
Yeah,
is
we
my
have a
point.
lot of
Oh, yeah.
we have a lot of goals for it, so the kids can come directly in there for the same-day screenings instead of coming to our walk-in and
I was
counseling
just thinking of
center,
safety
so
in
we're,
terms of
yeah.
the
It's a very short breezeway,
I
but
know
they
it.
won't be,
No, they don't walk back and forth, it's, yeah.
and the cars still come rumbling through, I'm sure.
That's true,
On
yeah.
occasion.
Yeah.
I would just say in support of it with Phil and others, Frank and I toured it. It's bright, cheery. All the rooms are assigned to Tyson teens and to the other groups. And the integration between the two centers that come in the right and the left, I thought was very well done. And
Thank you.
looks like a good program.
Thank you.
so are we ready to call the motion?
I will. Move to fund this program.
I would second it.
And all in favor?
Aye.
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 Aye. Okay,
Thank you.
all right,
Thank you.
Thank you.
all right.
Thank you very much.
Thank
Take
you.
care of those kids.
Okay, it's not Jennifer, but Robert, you're gonna do the resolution?
Sure, this is resolution number 2024-01, regarding voting document regarding the sale of parcels. Very simple resolution, just authorizing you as chairwoman to execute any and all closing documents regarding the sale and purchase agreement. So by approving this resolution, the trustees will be giving you that power, and it looks like everything will be closed in April. That's when the deal is going to happen, so everything is going forward, very happy with it.
April 8th is our date, right?
So moved.
Second.
All in favor?
Aye.
Aye, okay, thank you. Would you pass that down for Barbara to sign, to do that? Okay, Paul,
All right.
you have 10 minutes.
I know we have time constraints, so I'm, just for clarity, I did not come here tonight expecting that we were going to take any significant action. I was just trying to provide food for thought and share some background and take a look at our governing documents. My observation, I am one of the newcomers to the organization. My observation is that historically, and Jennifer Peschke shared with us early on in the history of the district. Fortunately, we are not in that position, but the elected trustees were in the position of being directly involved in the day-to-day operations. That evolved into the Indian Memorial Hospital, Inc. coming into existence and being the entity responsible for running the hospital. 2018, effective 2019, was the lease agreement. Together with that lease agreement was the substitution agreement. Substitution agreement provided that Cleveland Clinic would now occupy the corporate existence of Indian River Memorial Hospital, Inc., would have 9 of the 17 board positions at their discretion to be appointed, and then a majority vote would approve the remainder of those members. Standing back, looking at that, together with the differing perspectives between a locally governing entity and Cleveland Clinic, I think there's some needs that we as the Board of Trustees, I think, are statutorily obligated to look into and try to fill. And then the next question is, well, how do we go about doing that if we are so inclined? Our mission statement is very different than Cleveland Clinic's mission statement. Ours is to improve the health of Indian River County residents. Their mission statement is caring for life, researching for health, and educating those who serve. Our mission is very local. We received a letter when we were informed that the governing structure was changing that included this sentence: our new operating model will position us to become a fully integrated global organization which delivers consistent care everywhere that we serve patients. My concern is that there's a vacuum that's been created of, I won't call it home rule, but home interest that we I think, as trustees, need to explore and fill. Looking at the special act, we do have authority under Section 2 to be responsible for the quality of care that's being provided in the county, that it's ours, irrespective of who else is filling the vacancy or the occupying the space in the hospital. It is still ours. Section 12 talks about the medical staff and the staffing obligations. That is ours first for that hospital facility.
When you say ours,
It's the districts. It's the districts. It's the trustees, because the special act says so, that it's our primary responsibility. So we have primary responsibility for oversight to some degree of Cleveland Clinic. There's some that say, okay, well, we don't want to get into day-to-day operations. Agreed. I don't want to have an office at the hospital. I don't. But I think we have things to offer them by engaging with them, maybe setting some standards, seeing how we can go about it. Some of the anecdotes is, I have a local doctor until I don't, and then I've got to go to Weston. Well, are we providing medical care locally when the answer is go to Weston? Perhaps, given our statutory requirement under Section 2 and 13, we need to engage with the hospital and say, you know what, locally, these are the specialties we want covered, and let's work to doing that. Now, I understand that the industry right now is having difficulty filling positions. The existence of that issue doesn't remove our responsibility. I still think that we should be engaged in some way in this regard. I use a specific example in my materials, the form regarding the informed consent. that is off-putting to a lot of patients. And there are people that will decide to go elsewhere over that form. That form comes from Cleveland. I think that it could be tweaked a little bit and be much less objectionable. I brought it up twice, once in July when Dr. Peter came to our chairman's meeting, in October when he was here. I haven't heard anything from him. On the issue of indigent care, the lease agreement is set up such that in exchange for being able to operate the hospital, there are two lease rental obligations that they have. One is over the first 10 years of the lease, I believe it's a $250,000, $1 million commitment to provide capital improvements. The capital improvements can be what we traditional think are capital improvements, can also be maintenance items. The other element of the lease is providing indigent care. And I think another area that we need to explore, and I'm not prepared to say, hey, this is how we do it. Perhaps Frank can come up with a plan as to the areas that we would make inquiry. But I think we owe that to the taxpayers to be engaged with Cleveland Clinic. How long is it taking for somebody to get through the process of getting approved? Are there delays in medical care? And I'm going to give two examples that are completely extreme. I'm involved in a ministry, and one person involved in the ministry, catastrophic condition, indigent, great care, had to go to Weston, seamless care. Another person engaged over a medical condition over many years, and recently went in and a PA or somebody said, hey, what about this test? Is this test had never been done? What I was getting from this person, she didn't articulate it the way that I'm going to, but it was an undercurrent, is did I get different treatment because I'm in the indigent program? Couldn't answer that. She didn't ask it that literally. I would hope she isn't. I would like to be in a position where I have an informed basis, tell the taxpayers, no, Cleveland Clinic treats you the same as everybody. That probably is the case. But I think an audit puts us in the position of doing that. An audit may help us be better informed to help them. So what I'm suggesting is, I think we owe it to the taxpayers under the Special Act to uphold certain standards and responsibilities, that we need to be going to Cleveland Clinic and engaging with them in a collaborative way in order to facilitate a higher level of service. I know Frank has been working with them a great deal, to that end already. So anyhow, that was the topic of conversation. The memorandum that I gave you was to that purpose. I really think it's something that we meaningfully need to engage. And the next question might be, well, how do we get there? How do we insert ourselves? And that's in section 11, I believe, of the lease, rules and regulations. And we have rulemaking authority over any property we own, period, whether it's occupied and used by us or someone else. I wouldn't want to use that. I would hope that we would be in a position to be able to interact collaboratively and work together as a team. But I think we have stuff to offer Cleveland Clinic. And Mary Beth, I know you attend the board meetings. I'm sure you're contributing in that way. But for us, there's a huge vacuum. I have people coming to me all the time with this complaint and that complaint, and I'll sometimes send them to Frank. What I will tell you is I've never had anybody come to me and say, I've had an issue, this is the issue, and you know what? The person on the other end of the phone or at the office suggested I use the ombudsman. We've heard about the ombudsman, but is it being fully implemented and carried out the way that it should be? So I would like to see our community have a higher level of satisfaction with the hospital because things are going better. And, we've had conversations. I think at the October meeting, there was a big discussion about, some of it may just be PR, that if they were better at their PR, things would be better. There are hundreds of people that are giving reviews that have had personal, real experiences that would say, no, that wasn't PR. That was a personal, real experience. And I think we owe it to the community to help Cleveland Clinic do better. They can do better. I think they want to do better. This isn't me throwing rocks at them. This is me saying we owe a responsibility as elected officials in the community to figure out a way to engage and to contribute. So that was the purpose behind all of this. And on the first step on the audit, I'm going to probably get together, since we're short of time, I'll probably get together with Frank in the meantime and say, you know, based on your experiences and where you've been, what would an audit look like? What kind of questions we would look like? And have a...
Is that what we want? And I know you want it, but is that what we want our executive director working on when we have so many other?
That would be for us to decide. Be for us to decide. If you don't want me to talk to him on that, fine, I won't.
I just think that that's.
We'll just leave that topic alone and
If we're going to give direction to him to do an audit.
no, I said what an audit would look like was all.
But if we want to give him direction on that, I think that we all have to have discussion about that, rather than when Frank has we have so many other things that need to be looked at. I mean, we're looking at a substance abuse, you know.
This board can choose to do nothing in regard to Cleveland Clinic if it chooses to.
I don't think that we're doing
stipulated.
nothing. I think we're letting them manage their business the way that the lease has been drawn up to.
But the interesting thing is, the lease specifically at section 5.5 states that Cleveland Clinic agrees to adhere to all local ordinances and statutes and laws. Well, section 11, section 2, and section 12 are parts of the public law. They are parts of the enabling statute that created the hospital district, that create the responsibility in us. And if somehow a lease that doesn't negate the statute, that clearly says we're going to follow the law, somehow that still leaves open the opportunity for us to say, you know what, we're just going to let them continue to do it and struggle and do whatever, and we're not going to be engaged, and we're not going to try to intervene and help for the sake of the taxpayers. So be it. That's going to be our decision.
I don't want to say we're not going to intervene, we're not going to do something for the help of the taxpayers. The question really gets to be is how we go about doing that, right?
Right.
And how we engage with them and in what way is helpful to them to do.
Right.
Okay? And I think this takes some real discussion at another meeting. And I'm not trying to put it off. What I'm trying to say is I think there are ways we can help them. We need to bring some things to them. We need to say some things. As far as indigent care, you know, I mean, they have to report on it. The question is, you know, I guess your question is, are they getting good care? Is anyone getting good care?
I would agree. I was going to say the same thing Mary Beth just said. I think this requires, you brought up a lot of diverse areas.
Agreed.
I would
And I wasn't, that's why I started the way that I
agree
did.
The report for signed consent is 3 pages long and hard to read, and from my practice as a physician, not acceptable the way it is, because there's not even a surgical consent form that specifies out what all the complications things would be. So that was one, was the surgical consent, indigent care is another one of concerns. So this requires, I think, more strategic planning.
Exactly. I'm not expecting that in 10 minutes we're going to answer this necessarily.
bring up
So, none at
good
all.
questions.
Not at all.
I think what we want to do is let's take the time to maybe parcel what those issues are. Okay?
Agreed.
And then figure out a way to be able to deal with it.
Sure.
tell you what.
And maybe what we do is we ask Cleveland Clinic to have one of their people, if you would, be a liaison to us rather than me being on the board, because I can tell you quite honestly, I mean, there's not a lot of.
Well, you're between a rock and a hard place because you have confidentiality obligations.
I do.
So you can't report to us.
I can't, not some things. Some things I can, okay? But maybe they do have a liaison to us, okay, that we can work together on.
And this is about unintended consequences surfacing in the relationship that we need to work on. is the point of the conversation. So the templates were the form, the audit, just as examples. I'm not saying that we need to, hey, we're going to audit them today. Those were examples, and each of you may have your own. So anyhow, I appreciate your time.
My observation is now 3 times seeing Dr. Peter present. I mean, his programs are much more inclusive, much more clear, but he needs, personally, I think he needs help in presenting all this, and administratively, I think people at Cleveland Clinic get great care. I think administratively, what you're talking about, that's where the rub in the road comes, because they're not he doesn't have the people, or at least that I can see, helping him administratively address the issues that you brought up, Paul. And I think a number of them, for example, indigent care. By the Healthcare Act of Florida states that requires all non-for-profit hospitals to take care of indigent patients in a tax exempt, if they have a tax exempt status. And I'm not sure they're doing it all as they could. It's just one example.
I would be very, very careful saying that, okay? First of all, they have to report to us on that. That is one of the things that's a requirement for them to report on. They do. They have a whole section in their report and all of that. What you're saying is, are they doing it? His question is, how well are they doing it and how fast are they doing it? Okay, those are different issues.
Well, but
So we need to take these apart.
hearing both of you, you're right. But when I see the report, in services, we've provided services valued at X this past year. My recollection, I have the report in front of me.
They talk about how many people
Yeah.
they've seen, and they talk.
Okay, I'll have to look at it. But
My quick take here is, I think I'm hearing you say, Paul, that this board has some greater responsibility, number one, and perhaps greater authority than we think we have in some aspects of their operation.
correct.
One of the things that goes, you're a lawyer, I'm sure you are a damn good lawyer. What does our counsel say? I mean, is it an interpretive decision that you make? Is there some interpretation in the language that makes you think that, or are you pretty confident? I'd like to hear what Jen would have to say.
And it also is a matter of how much do you want to take?
Right,
As a
and
board.
that's where I was
There's
headed.
a difference between getting active and setting standards or making guidelines.
I guess I wonder about the and again, I think we should get into this in a different discussion.
Strategic planning?
Yeah, maybe that we spend a whole time on that.
Maybe a strategic
And
planning
maybe what we
session.
do is have a strategic planning session and we invite somebody from there to participate.
That would be great.
There's just one something I wanted to add to this that's small, but I think it's important y'all know, is that every interaction I've had when I've had a question for Cleveland, whether it be directly to Dr. Peter or to their outgoing CFO, Warren, or their outgoing COO, Alex, or the incoming, Gabe, they've been responsive, receptive, and so when it comes to an open, in no way with requesting anything, getting information, having dialogue, I've not been stonewalled, nothing like that. There's an open chain of communication, open line of communication now. What we want to do with that is up to the trustees, but I just wanted to state that. So we have that ongoing dialogue, to Paul's point, now.
So what I would like to do is I would like to put this, and let's talk about this at the either April meeting or set a separate meeting to be able to do this and be able to get in
That would
and
be great.
understand not only what it is, that the issues, but how it is we would like to approach it as a
Super.
board. Okay?
Thank you.
Can we do that?
Agree.
Okay. Do we have any other items? Any public comment?
Is your public here?
There's a couple public here. Okay, hearing none, we are adjourned for the night.
Thank you.
Thank you.
Sticks on the